amazing talks. It's a privilege to have Gaurav over here. He's consultant radiologist at Sankarshan Imaging Care Arthro Center at Jyoti Hospital, Gurgaon. And he has done MSK Imaging Fellowship from Innovation Imaging, and he has also interest in immediate guiding interventions. Today's topic for Dr. Gaurav is bone marrow edema in knee, patterns and insights. So thank you so much, Gaurav, for taking time out, and everybody loves your teaching. So I hope we are going to have an amazing session tonight again. So all over.
Thank you, Ankita, for an invitation. I'll just try to do whatever I can help out with practical points, because this is one of the most common areas which we see in our daily practice. So thank you so much for the invite. Should I start now?
Yeah, all over to you.
And my screen is visible, right?
Yes, yes.
Okay. So good evening, everyone. Thank you all for joining in this session. So my topic for today is a marrow edema pattern in knee, which is one of the most common scenarios we encounter in daily practice. So we will be discussing various patterns and learn some insights out of them. So bone marrow edema, when I was in my early days of training, so I always thought that edema is either inflammatory or infective. But as we start reporting cases and reading a variety of cases, we get to know how this bone marrow edema can fit into a big spectrum of disorders, right from physiological to pathological. So this is a list which we commonly see in our practice. So be it physiological, metabolic, infection, or inflammatory disorders, trauma, which would be fracture, bone impaction, stress-related injuries, epiphysitis, ligamentous injuries, patellar instability, degenerative stuff, trauma, and neoplasm. So a whole bunch of spectrum comes which presents as a bone marrow edema spectrum, and let's learn how we can approach it according to the area of involvement. So firstly, I would like to discuss a few basic sequences which we acquire before we identify knee pathologies. So we should have good imaging, come what may, so that we are sure of what we are giving. So the fat suppressed images are the best images to look at bone marrow edema. As we all know, as the fat gets suppressed, so it's a bright signal in dark background which is seen. So stir, proton density fat sat images or T2 fat sat images are the suitable fat saturated images which we see, and according to different machines, whichever suits your system, you should acquire them. They can be acquired in sagittal and coronal plane, and pattern of bone marrow edema helps to identify the cause of pain. Then T1 weighted image differentiates real bone marrow from red marrow. So at times we will have confusion that whether it's a true marrow edema or not. So T1 is a very essential sequence wherever there is a bone marrow edema pattern, specifically when there is tumor and infections involved. And proton density non-fat saturated images I usually acquire in my practice to look for menisci, cartilage, and ligaments. So these are the various patterns of bone marrow edema, like the areas of affection. So one is the periphyseal, which is adjoining the growth plate or the physis. And second is the epiphyseal involvement, which is at the attachment of the tendons and the ligaments. Then next is the subchondral pattern. Next is femorotibial translational pattern or the kissing contusions. Next is anterolateral femoral and inframedial patellar, as we see in certain dislocation events, and diffuse pattern of marrow edema. So my first pattern will be the periphyseal edema. So whenever we look at bone marrow edema around the growth plates, one should think of certain differentials in their mind, not just vague, but then what all can be the differentials. So let's have a look at one by one. So the first entity which I will be discussing is a periphyseal edema zones, which is physiological. So the 4 zones are physiological and seen in almost pediatric age group till the time of puberty. And these present as bright signal on the fat saturated images. So these are focal periphyseal bone marrow edema zones, and they are physiological. At times they can contribute to pain while there is growth spurt, but whenever there is a pattern of marrow edema around the growth plate, one should not consider this as pathological unless it is florid, and as we will see in other conditions. So this is my first pattern which I wanted to show, and this everyone should be familiar with this condition. So as the child starts to age, so the growth plate starts to fuse, and there is physeal fusion as we see in this case. So these are the proton density non-fat saturated images, and we can see the cartilage and the menisci well on these. Along with that, we can see how the growth plate is getting obliterated with the growth. Next is a case again of the periphyseal bone marrow edema. So as we all know that this is the MRI of a skeletally immature patient, and we can see the growth plate which is not yet fused in the distal femur. But as we see in the proximal tibia, the growth plate, there is bone marrow edema around the growth plate, which is seen on the fat saturated image, and there is obliteration here. So this is secondary at the time of puberty when there is growth spurt, and this can be a cause of a transient pain in an adolescent knee. Another case where if a patient comes with a history of trauma, growth plates are very much amenable to traumatic events, and any separation we should think of a Salter-Harris type injuries. And as we see that the growth plate here is separated along the lateral aspect and along the medial aspect, and what we see is that the dark periosteum here is stripped off and is entering into the widened growth plate. So this is a trapped periosteum with physeal separation injury, and we can see bone marrow edema pattern along the growth plate. So see how beautifully we have come from a physiological to a pathological condition, right from a periphyseal focal zones to puberty spurt to a physeal separation in a Salter-Harris type injury. Next is a case when there is an impactional injury, when the bone has just banged on a hard surface, and there is an impactional bone marrow edema, which is again adjoining the physis, but the growth plate appears intact. And what we also see that there is mild swelling or softening of the overlying cartilage, which is seen better on the non-fat saturated image. So this is a normal growth plate pattern, but there is impactional edema in the epiphysis, and there is chondral softening. So the child is presenting with pain here. Another case here we see is another case along the growth plate is along the anterior aspect and along the metaphyseal region. So this was a case where there is a metaphyseal fracture, as we see that there is bowing of the anterior cortex of the distal tibia, and there is bone marrow edema tracking along the growth plate here, as well as in the periosteal region and in the prefemoral Hoffa's fat pad. So different conditions are there. So this is a differential diagnosis, which is a physiological event. So a posterior metaphyseal stripe is a physiological sign which we see on the posterior aspect of distal femur, and this is surrounded by a dark rim. So a cortical desmoid and posterior metaphyseal stripe. So whenever we see such, so these are physiological normal appearances in pediatric knee. So we should know the pitfalls also, and we should know what is normal and what is abnormal. So periphyseal, a lot of pathologies coming from the focal zones, from the traumatic events, from the ranging from the periosteal stripping, Salter-Harris injuries, impactional injuries, and we should know the normal anatomical or normal developmental variants. So again, as I said, that the FOP or the FOP zones are localized to the periphyseal area, but when we see flame-shaped areas, these are pathological. So in such cases, as we see that there is subperiosteal edema as well, and flame-shaped broad-based areas of marrow edema, one should think of non-bacterial osteitis or chronic recurrent multifocal osteomyelitis. Similarly, in proximal tibial metaphysis, we can see that there is flame-shaped area of marrow edema here in the tibia as well. So pattern of normal as well as abnormal marrow edema, we should look at multiple, and this is a T1 weighted sequence. So see how this bright area is seen as dark area on T1, and this is darker than the surrounding muscle. So if this area is equal to or less than the surrounding muscle signal intensity, then it is a red marrow. But then T1 helps us to confirm the pattern of marrow edema. Next is a case of metabolic event in which again we see that there is widening of the physis, there is surrounding bone marrow edema, there is metaphyseal irregularity along the growth plate, and so this was a case with a child who was vitamin D deficient, had early rickets, and had presented just for the MRI of knee. So these were the patterns of periphyseal marrow edema. So we have seen right from physiological to pathological events. So next pattern what we see is the epiphyseal involvement. So epiphyses are these are the basically soft areas in the pediatric knee, and as the child is more physically active, so in such cases these areas are amenable to more injury, more prone to more injury. I would say that because these are the soft areas, so there is more stretch and repetitive traction over that sides, which leads to swelling, inflammation, and pain. So two common conditions which we normally see in our practice. One is the Sinding-Larsen-Johnson syndrome and Osgood-Schlatter syndrome. So Sinding-Larsen, so this is a case of this is a sagittal proton density fat saturated image. Okay, and as the fat is dark here, this is a corresponding T1 weighted image. And in this case, we see that the bone marrow edema is epicentered at the level of inferior pole of patella, which is at the site of patellar tendon attachment. So whenever there is such a case, when there is traction over the epiphyses, so these are soft areas, and this is a this is a skeletally immature patient. So this is a pediatric knee, and these epiphyses get traction, and hence there is bone marrow edema along the inferior patellar pole with a thin kind of a stress over this bone. So, and there is associated edema in the Hoffa's fat pad. So this is referred to as Sinding-Larsen-Johnson syndrome. And on the T1 weighted image, we can see how this epiphysis, which is not yet fused, is getting affected here. Another case in which we see that this is the patellar tendon, and this is the proton density image, again a fat saturated image, and this is the tibial tuberosity. So where the patellar tendon attaches at the distal attachment at the tibia, so when there is traction epiphysitis, there is inflammation at the tibial tuberosity. So this is a case of Osgood-Schlatter disease. So along the proximal aspect, when we see, it is called a Sinding-Larsen-Johnson syndrome, and on the distal patellar attachment is called the Osgood-Schlatter disease. Okay, so there is associated pre-patellar soft tissue edema in the subcutaneous fat. So most common type of epiphysitis injuries are Sinding-Larsen and Osgood-Schlatter disease. So along with that, there is a condition with acute and chronic Osgood-Schlatter. So as we see that there is more osseous remodeling which is happening at the site of tibial tuberosity, and there is intraosseous cystic changes along with patellar tendinopathy at the site of distal patellar tendon. And here we can see that there is less involvement, but there is thickening and chronic scarring at the tibial attachment of patellar tendon. So these are the cases where we can say that this is acute or chronic. So how we can see that this bone marrow edema pattern, and the patient is quite symptomatic here, as we also see soft tissue edema in the subcutaneous soft tissues, while in the chronic case, there is no subcutaneous edema, no marrow edema. So this is a case of acute Osgood-Schlatter disease, acute on chronic, I would say, and this is a case of chronic Osgood-Schlatter. So next pattern of bone marrow edema, which is one of the most common patterns which we encounter in middle-aged individuals, is the subchondral bone marrow edema. So subchondral bone marrow edema, what we can think is, so subchondral means below the cartilage, so it can be secondary to a cartilage erosion, or it can be due to an osteochondral defect, or it can be due to a focal cartilage defect rather than a diffuse involvement, or if there is a sports injury and there is any dislocation event, or if there is any impaction injury and the bone has come up, so a chondral delamination. Then osteoarthritis, which is one of the most common scenarios we encounter in the elderly age group. Okay, and disuse osteopenia secondary to post-operative event when the patient is on rest and cast. So subchondral bone marrow edema is seen in such situations. So let us have a look at the following examples for this pattern. So These are sagittal images. So this is the proton density, non-fat sat image. See how we can beautifully look at the gray intermediate signal cartilage, which is separable from the meniscus as well as the joint fluid. So the meniscus and the cartilage, I use a proton PD, non-fats image, more than the T1. Again, as I see that this is a fat saturated proton density image, and we can see focal bone marrow edema here. And this is a T1 image where we can see that there is some trabecular microfracture along the subchondral area. So this was a case of mild subchondral insufficiency or a stress edema in this bone. So this is more pronounced. As we see, this is again a fat saturated sagittal image, and when we see that the bone marrow edema is out of proportion to what we are to any other finding, so we should try to look for a subchondral fracture line. So in this case, which is a fat sat image, we can see that there is cartilage thinning along the tibial aspect of the medial tibia, and we can see a hypointense fracture line underlying the chondral plate. So this is a subchondral hypointense fracture line, or it is called a subchondral insufficiency fracture leading to moderate bone marrow edema. So this is secondary to a stress on the bone in which the microfractures occur in the bony trabeculae. Along with that, we see Baker's cyst, which is not yet ruptured and it is just incidentally seen. There is associated degenerative signal in the posterior horn of medial meniscus, but no discrete tear at this time. Next example of a subchondral insufficiency fracture. So now we can see that there is florid bone marrow edema both in the medial and lateral femoral condyles. It's more so on the lateral aspect. And when we can see that whenever we see such a pattern of bone marrow edema, which is unexplainable to the patient's symptoms and to other findings, so let us always look at the subchondral hypointense fracture line. So this hypointense, or the dark area which we see, the linear, so this corresponds to a subchondral hypointense fracture or a subchondral insufficiency fracture. The cartilage here looks more or less good. The body of menisci is intact. And because of this edema, there is surrounding soft tissue edema deep to the iliotibial band. So this was a subchondral insufficiency fracture involving both the lateral and medial femoral condyles. Next example is an osteochondral defect, which is usually seen in adolescent age group. And when we see a discrete area where the cartilage and the bony fragment together gets delaminated or separated from the parent bone, then we need to look at what is the pattern of the osteochondral defect, whether it is a stable defect or an unstable defect. So all these things we need to mention and give the size of the lesion. So firstly, what is important in such cases is that we need to give the anteroposterior and the transverse dimension of the osteochondral fragment. Second, we need to tell whether this fragment is stable or unstable. So if there is a fluid rim surrounding the site of defect, then we can say that this is an unstable fragment. Or if there is no fluid rim and there are only subchondral cystic changes or marrow edema pattern, then we need to tell. So as this is in the subchondral area, and we can see that this is a complete defect, which is a stable defect almost. So this is a case of osteochondral defect, and this is majorly on the inner lateral or the inner medial aspect of the femoral condyle. So this is a case where there is a displaced fragment associated with osteochondral dissecans. So here we can see that there is a complete focal defect in the bone, in the subchondral bone and the underlying cartilage. And on the proton density image, we can see that this is a bony signal and this is a separated OCT fragment, which we are seeing in the intercondylar notch. So whenever we read such cases, we should be aware of what all areas we are looking at. So this is another case in which there was an osteochondral defect, but now it has healed. There is cartilage fibrillations, which we are seeing in the central weight-bearing aspect, but there are subchondral cystic changes, which we are appreciating in the central weight-bearing medial femoral condyle. So this is a case of degenerative process like a patellofemoral osteoarthrosis. So subchondral, as I said, the subchondral pathologies are the most common ones in middle age to elderly age group. And whenever we come across a knee MRI, whenever we look at any marrow edema, that's what I said in the beginning, for the beginners, infection inflammatory should not be the only thing. We should look at what has caused it. So as we see here that the two bones are opposed to each other, there is loss of a complete denudation of the femorotibial, the patellofemoral articular cartilage here. So this is a case of patellofemoral osteoarthrosis, which has led to subchondral cystic changes and mild marrow edema in the subchondral bone. So along with that, we can see this is the trochlear area. And again, there is high-grade cartilage loss here, grade 4 chondromalacia as people say. So this is subchondral bone marrow edema in the trochlear region. So this is a proton density image, and this is a fat saturated image. So certain times we see that the cartilage, there is no delamination, there is no loss, there is no chondral defect, but we see that the cartilage is appearing brighter than the normal cartilage. And at times it appears brighter as well as swollen. So in such cases, what we say is called a chondromalacia or chondral softening. So as we see that this is the cartilage signal here on this image, and focally we see here that the cartilage appears swollen and it has more of fluid signal because these are iterated sequences. So on these fat saturated images, we can see that the cartilage has swollen up here, and this is possibly the cause of pain in such patients. So this is an example of chondral softening in the superior trochlea. Along with that, chondral blisters, along when they are present focally, they can present as increased signal intensity amidst the intermediate gray zone of the cartilage. And along with that, there can be areas of subchondral cystic changes, marrow edema, as there is resistance, the area of least resistance comes. So it can penetrate into the subchondral bone and the fluid can go inside. So this was a case of chondral blister. Next case, another degenerative case, what I wanted to discuss is an advanced arthrosis. So whenever there is high-grade chondral loss, the cartilage appears completely gone. There is close apposition of the bone. The two bones are coming together. There is associated meniscal tear, and we can appreciate that there is subchondral bone marrow edema. So this is again a case of osteodegenerative process leading to subchondral edema pattern. At times what happens is that there is radial zone chondral delamination. So these are the deeper zones of the subchondral plate, and whenever there is like delamination or separation of the cartilage from the bone, the fluid can seep in and produce an area of marrow edema. So this is a subtle case actually where we can see that there is slight elevation of the cartilage from the subchondral bone, and there is appearance of mild marrow edema in the central tibia. So this is a pediatric age group as the growth plate has not yet fused, but as we can see here that there is subtle elevation or delamination of the cartilage from the subchondral plate. So this is a small little subtle area of delamination. So usually the cartilage should present completely and homogeneously like in the case of femur, but on the tibial aspect, what we see is that this cartilage is slightly elevated, and this is the site what we see here on the pattern of marrow edema, which is corresponding here. Next is a case where we can see that again there is medial compartment osteoarthrosis, and you can again see a chondral delamination here, that this cartilage is lifted up from the subchondral bone plate, and there is degenerative subchondral cystic changes, and definitely marrow edema, which would be seen better on the fat sat images. So these degenerative knees are very commonly seen because most of the patients who will come for MRI, they will come for the evaluation of various compartments. So whenever everyone knows on the X-ray that the patient has grade 4 arthritis or a grade 3 arthritis or a grade 2 arthritis, but what is the advantage of getting the MRI done is that they can actually evaluate the 3 compartments so as to evaluate so that the patient can be taken up either as a candidate for total knee replacement or a unicompartmental arthroplasty, or if he's in a younger age around say 50, 55, may be given a chance for a high tibial osteotomy depending on how bad his compartment is loaded. So in that case, these MRIs are of great use, and you will all get these scans to read in your practice. So sometimes we wonder why we are getting OA scans or osteoarthrosis scans, and we really don't want to read them. But whenever we get them, the idea of getting the scan is what information the orthopedic surgeon is wanting, that he would need information from all the compartments: the medial femorotibial compartment, the lateral femorotibial compartment, the patellofemoral compartment, the status of the ligamentous structures, and accordingly then they will decide what is the. So whenever you report such cases, you have to, in your impression, it should say that if it's a medial compartment osteoarthrosis, then the second point should say what is the compartment on the lateral aspect looks like, if it's normal, or what is the grade of cartilage loss. And similarly, the third should be your patellofemoral compartment. Along with that, the menisci and ligamentous structures, all those details will be evaluated and described in your report. So this is a case of advanced unicompartmental OA. Now we see that there is high-grade chondral loss or cartilage loss in the central weight-bearing medial femoral condyle, as well as along the peripheral medial tibial. So this is a case of a moderate OA of the medial aspect, as some of the cartilage is still preserved on the inner aspect. But as we compare on the lateral aspect, just look how beautiful this cartilage is preserved, both on the lateral aspect of the femur as well as the tibia. So we see that the meniscus, the body is extruded out in the medial cutter. So possibly there must be a root tear somewhere, or in the posterior horn there must be a tear, which is the most common associations with osteoarthrosis. So the idea of showing these cases from mild osteoarthrosis to moderate and advanced is how not just the pattern of marrow edema has to be given in the report, but what information the surgeon wants from us is what is the status of the cartilage, the meniscus, and other structures around the knee joint. So next interesting topic is the post-chondroplasty cases. So whenever there is an Oates procedure, or whenever they drill the bone, and sometimes they take out an allogenic grafts. So whenever they will do a cartilage transplant, so after 3 months and 6 months, whenever we do a follow-up scan, so we will need to tell what is the status of the cartilage, whether this is congruent with the rest of the cartilage, or the cartilage thinning of the cartilage graft what they have put in is thin, thick, what is the thickness, and what is the status of the underlying bone, whether there is bone marrow edema, whether there is mild fluid, moderate fluid, or severe marrow edema in the bone. Accordingly, they will put the patient on rehab, and then accordingly he will be managed for his rehab and for the exercises. After this post-chondroplasty procedures are done, so the patients are followed up at 3 months and 6 months, and later at 12 months period in our setting. And these 3 MRIs are performed within a period of 1 year. And the information which they want is what is the status of the graft, whether it has incorporated with the parent bone or not, whether there is bone marrow edema associated or not, or what is the congruity with the adjoining cartilage. So all these things we have to mention in post-chondroplasty cases. So whenever, if it's an early case, we will usually see that there is some pattern of subchondral bone marrow edema post. So that is not infective or anything like that. That is just the incorporation of the cartilage which is happening at that time. Next case which we see is again a subchondral pattern. So this is the cartilage, and below the cartilage we see these patchy hyperintense foci in all the bones. So these are like little weird. So if you see, this is a subcortical hyperintensity. Again, this is a subcortical hyperintense signal. So in cases when there is reflex sympathetic dystrophy, or in cases of disuse osteopenia in patients who have been on cast for a long time, so such signal appears, and this is a classical appearance in such cases where secondary to disuse there is reduced density in the bones, and hence it gives such an appearance. So in subchondral insufficiency pattern of marrow edema, we should be aware of all these patterns. So again, this is a case where we see subchondral patchy bone marrow edema in the subcortical area, and you see it's kind of distributed at different places. And along with that, we see that this is a discoid lateral meniscus on a PD non-fat saturated image. So diffuse osteopenias are very rarely seen, but then whenever they should not be confused with any other pattern of disorder. So we have covered three patterns. One is the around the growth plates, then second was along the apophysis, and third was along the subchondral bone. So these are very commonly seen areas which we will encounter in our daily practice every now and then. So let me come to the fourth pattern, which is again the most common pattern which we encounter because of the rise of sports activity, soccer, cricket, and kabaddi, and wrestling. So we see so many everyday femorotibial translational patterns are seen. So the ligamentous structures, they try and maintain the stability of the knee joint, and whenever there is any break or any acute event which has happened which has led to stretching of the ligament, whether it is a stretching which could be a low-grade injury, or some of the fibers have disrupted, which is a partial tear, or if there is a full thickness tear of the ligament, then that leads to instability. The two bones come and bang on each other, and they produce a femorotibial translation bone marrow edema. So whenever there is translation, either anterior, and the femur goes anterior to the tibia, the posterior and the anterior surface of the bones will bang against each other and produce a pattern of marrow edema. Okay, so whenever you come across a knee joint and you see this kind of pattern of edema, which are like the kissing contusions, so the mind should go that this patient might have an ACL injury, which is one of the most commonly torn ligament. So this is a case of a proton density. In this case, we see that this is a proton density image, a fat saturated image, and we see marrow edema in the anterolateral femur and posterolateral tibia. Okay, and along with that, what I see is the bow-shaped pattern of the menisci is lost. I don't see anything posteriorly, but where it is gone? So we see that this soft tissue structure, this fibrocartilage, the meniscus tissue has come anteriorly. So this is a case of a flipped meniscus, where the meniscus a portion has come anteriorly, and on the corroborated images, we can see that the meniscal flap here in the intercondylar notch against the PCL. So this is a case of a bucket handle tear of the lateral meniscus, and the ACL is completely torn here. So this is the full thickness tear of anterior cruciate ligament. Along with that, we have a bucket handle tear and a flipped meniscal flap anterior to the anterior horn. So again, in the next example, we see this is again the anterolateral femur. This is the posterolateral tibia. So again, the most common pattern of bone marrow edema which you will encounter in a young patient, I would say, after a twisting injury. Now, even I saw a case after a dance party, the patient just twisted his knee and came up with such a pattern of edema with an ACL tear. So in this case, the meniscus looks okay on these sagittal images, but when we look on the coronal image, we can see that there is a small meniscal flap which is entering into the intercondylar notch, suggesting that there must be a tear in the other sequence, in the other sections. So meniscal tears are most common associated injuries along with the ACL injuries. So the pattern of tear has to be explained well. If there is a tear in the peripheral third, in the body segment, in the posterior horn or the anterior horn, whether there is a displaced flap or not has to be told. Then we need to tell if there is any osteochondral fragment or a chondral delamination. So those things are very important in such cases of ACL injury. So double PCL sign, as I said, that this is a case of an ACL tear with displaced meniscal tear, and so this is the bucket handle fragment, so giving a double PCL appearance, so most commonly seen with ACL injury. Another thing which I wanted to tell is a ramp lesion. This is one of the most commonly associated, along with medial meniscal tears, a very commonly seen phenomenon and often missed in most of the daily reporting for the knee joint. So the ramp lesions are one of the most common sites of injury associated with ACL. So because these are, you need to inform your arthroscopic surgeon or the knee surgeon about this, because this will not be seen on the normal scopy. And even after the reconstruction, if we don't address this, this can lead to ACL reconstruction failure. So whenever you see a a medial meniscus tear at the meniscocapsular junction involving the meniscotibial attachment or the femoral attachment, we need to at least raise a concern for ramp region so that they can just guide their scope back along the posterior horn, because that's not very common, easily seen, and then they can go and repair if it's the case. So ramp lesions, you should go, there are beautiful articles available on the web, and you will actually see, when you know this term, when you know how this looks like, you will mention these things in the report and obviously gain credit for it. Another commonly seen area is a Risberg rib. So along the ventral aspect of the PCL is the ligament of Humphrey, and on the posterior aspect is the ligament of Risberg. So the Risberg ligament comes and attaches on the posterior aspect, on the posterior horn of lateral meniscus. So whenever there is ACL injury, at times there is ripping apart of the Risberg ligament from the lateral meniscus attachment. So whenever we see a case of ACL injury, we should always look for a peripheral longitudinal tear in the posterior horn of lateral meniscus and see whether this is extending towards the body or not. If it is, then we should mention about Risberg rib. So these are important areas which the surgeon would address whenever, so he knows that these are the conditions involved along with the ACL injury, he would go and repair them along. So this was a translational bone marrow edema pattern and associated things. Next is a Seagon's fracture, so which is seen at the avulsion fracture at the site of anterolateral ligament attachment over the tibia. So this is a Seagon attachment and the Seagon's fracture, which is a common spotter for the residents on the radiograph. Excuse me. So in cases of ACL and PCL osseous avulsion fractures, we will be able to see certain pattern of bone marrow edema. So whenever there is ligamentous avulsion, you will see marrow edema along the inferior aspect. Next condition I would discuss where we see a pattern of edema where there is the anterolateral femoral and inframedial patella involvement. So whenever we see such a pattern of marrow edema, so like we saw in the previous case, one would definitely think of that, yes, I found an ACL injury. But when we look at the ligaments, so sometimes we see that the ACL looks bang normal. So in such cases, we should next go and look at the inframedial aspect of patella, and if the bone marrow edema is seen there, then we should think of a term which is called a transient lateral patellar dislocation event. Okay, so when you know such things, what is happening and what are the things associated with certain areas of involvement, then your diagnosis will not go wrong. And when you know what is the diagnosis, you will be able to provide the necessary information to the treating doctor. Okay, so this is a case where there is moderate anterolateral femoral edema, and along with that, there is involvement of the inframedial patellar area. Okay, so this is a case of patellar dislocation or a patellar instability, and in this case, this is a medial patellofemoral ligament which is injured here. So this is the inframedial patellar involvement. You can see here, and there is associated osteochondral injury at the site which is leading to this pattern. So in such cases, it is important that when we have seen that there is a patellar dislocation event, we need to look at what is the status of the patella, what is the position and the morphology, whether it is Weiberg A, type B or type C. Then we need to tell whether it's a trochlear dysplasia or not. So trochlear dysplasia, we follow the DJOR classification, and we need to mention about classification, the type of dysplasia, whether it is type A, B, C or D, and give the tibial tuberosity to the TT-TT distance so that they can assess whether it needs a tibial tuberosity transfer or not. So in such cases, once as we can see that the medial patellofemoral ligament is stretched here and injured, the patella is laterally tilted, the cartilage is swollen out here with some radial zone delamination. So all these areas we need to mention in our report. Sometimes there is MPFL injury. Along with that, we see that the bony discontinuity is seen along the inframedial aspect and the small osseous avulsion here. So always look at if there is a displaced osteochondral fragment. So in this lateral gutter, in the lateral patellofemoral recess, we can see an osteochondral fragment which is displaced. So this is a very important area which we need to always look at double that you're not missing an osteochondral fragment, because that will change the surgical, or that will change the management to a conservative to surgical pattern. Excuse me. So MPFL injuries are the most common ones which need to be checked with these injuries. Then in cases of chronic patellar dislocation, what happens is when a patient has had a number of episodes of patellar dislocation, there will be bony enthesophytes and osseous remodeling changes along the MPFL attachment. And in this case, we can see that this is so poor. This is a poorly remodeled or a poorly healed MPFL or a medial patellofemoral ligament. Along with that, we see osseous remodeling changes. So next is a pattern of diffuse and localized pattern of marrow edema. So they can come in the case of infection or neoplasm. In the neoplasm, it may be benign aggressive or malignant. So a very common area which is seen in pediatric age group is the epiphyseal involvement. And if you see a huge or a florid edema in an epiphyseal location in a pediatric age group, and if you see that then you need to rule out an infection or a neoplasm. And so this is the proton density image of on a fat saturated image, and we see florid bone marrow edema, and we see an ill-defined lesion in the epiphyseal area touching the growth plate. This is the corresponding T1 weighted images where the lesion appears iso to hypo, and there is edema in the surrounding bone. And on post contrast, it shows nearly homogeneous intense enhancement. So such areas like chondroblastomas are one of the most common sites which affects these and present with florid edema. In cases of aggressive lesions, we see these are the classical case of a malignant lesion of the knee, and we can see that there's a lytic lesion in the distal femur involving the epimetaphyseal and diaphysis, and there is large extraosseous soft tissue area along with periosteal reaction, which we can see here. This is not a radiograph, but we can see that there is osseous, the bony changes, and there is all extraosseous circumferential component involving all the compartments. So this was a case of an osteogenic sarcoma. So on post-contrast images, it is showing heterogeneous enhancement. And we need to mention in such cases still what is the extent of the bone marrow edema. So the tumor surgeon requires the length so that they can actually see what length has to be salvaged and what length implant they need to put in. So this is a case of a marrow-infiltrative disease in which we see diffuse pattern of bone marrow edema, not a localized one. So the entire tibia here, the distal femur here, which is a visualized area. So this is a fat saturated image. Complete leg bones are involved with marrow edema, and these are the T1 weighted images, which shows complete drop-off signal on T1 weighted. So this was a case of a marrow-infiltrative disorder, and the child came out with positive blasts and high TLC count in this. So all the bones were involved. So these are the same patient, the foot bones involvement, the diffuse pattern of bone marrow edema. So this is a case of a leukemia. In certain conditions, whenever we see that there is collections and you see that there are cystic areas and then bone. So whenever there is fluid, just like a water body, it will just take path wherever it gets. Similarly, here in the body also same thing happens. So this is a case of diffuse patellar tendinosis with intratendinous collection. There is prepatellar bursitis and subcutaneous collection forming. And as this collection was diffuse in a long segment, this entered into the bone, producing a pattern of marrow edema here and various small collections. So this was patellar osteomyelitis with abscess. Next is the case of diffuse pattern of bone marrow edema. There is associated pathological fracture, and there was subcutaneous and intramuscular fluid collections which was extending along the anterior aspect of the leg. And so this was tibial osteomyelitis with fluid collection, abscess, and pathological fracture. So this was extending across the growth plate in the epiphyseal, but no evidence of intra-articular extension. So I try to make this slides so that one can get to know and get an idea of what all patterns and what all diseases which we encounter in our daily practice have their epicenter. So when we know the epicenter, we can actually think of certain situations, and when we know what is the situation, we can actually make our report in such a way that our treating doctor trusts us more and is happy with, so that the patient can be given appropriate care. So marrow edema is not always infective inflammatory, as I said, and I time and again repeat this thing because I have made this mistake in the past. Consider the age, pattern of marrow edema changes in view of clinical history. Systematic reading of images is important to avoid error. Look at ancillary findings which are associated with a pattern of disorder or pathology, and beware of normal growth patterns in pediatric knee. Thank you very much for your attention, and I would like to take any questions if we have.
Thank you, Gaurav, for such an amazing session. Can you just have a look at Q&A? We have a few questions.